आया है कि मुझे याद आया वो सातों में बस मलिग्नेंसी है
वो लग ही रहा था उसका लुक ऐसे।
वो है ना मुझे याद आया क्योंकि मैंने बताया वो ऐसे ही मास्क वो सातों में कर सकती आज देख रहे हो फिर ये तो मेरी समझ पहले ही
Today topic of discussion is chemotherapy, followed by response stratified chemoradiation therapy in HPV negative head and neck cancer, depend phase 2 non-randomized clinical trial, which is published on March 2025 in JAMA Oncology. Before talking about HPV negative head and neck cancer, let's talk about the HPV positive cancer. Uh, one trial, Optima 2 trial, which is published on June 2024, from the AJ Rosenberg et al., which evaluate the same neoadjuvant nivolumab to the chemotherapy followed by response stratified deaccelerated local regional treatment in HPV positive oropharyngeal cancer, which demonstrate excellent survival outcome, improved swallowing function, and lower enteral feeding rate with the deaccelerated treatment. So, building on the result of Optima 2, we hypothesize that adding nivolumab to neoadjuvant chemotherapy for HPV negative head and neck cancer would increase the deep response rate. What is the deep response rate? Deep response rate is defined as proportion of the patient who receive 50% or greater shrinkage of the tumor according to the RECIST criteria version 1.1. Patient with the tobacco and alcohol related HPV negative local regional advanced head and neck cancer, squamous cell carcinoma have poor survival compared with the HPV positive cancer. Currently, multimodality treatments such as definitive CTRT are associated with the poor outcome and 5-year survival, approximately 40% in non-viral head and neck cancer, along with the substantial acute and long-term treatment-related toxicity, approximately 43%. Therefore, strategy to improve survival while reducing toxic effect among the individual with the HPV negative head and neck cancer are urgently needed. For this, immune checkpoint inhibitor are targeting like PD-1 with or without chemotherapy shows improved survival in recurrent and metastatic head and neck cancer. For this, one trial has done in checkmate 141 in which compared nivolumab versus chemotherapy. So that trial shows with the overall survival of 36% comparative to the chemo arm 16.6% and response 1 year survival or response rate in the nivolumab arm 13.3% versus 5.8%. Despite of the promising result in recurrent or metastatic disease, the role of immunotherapy in curative intent head and neck squamous cell carcinoma with the standard fractionated chemoradiotherapy remain undefined. The response following neoadjuvant or induction chemotherapy is prognostic, which may facilitate patient selection for deacceleration treatment. Patients with the favorable response to the chemotherapy have superior prognosis and are less likely to experience locoregional failure after definitive CRT. Furthermore, in this article, we check the feasibility of response adapted dose and volume deaccelerated chemoradiotherapy in HPV negative head and neck cancer and consolidated nivolumab. The goal of this study is improve survival quality of life, decrease enteral tube dependence, and improve swallowing function. Basically, side effect focus ultimately. For the method, the deaccelerated therapy for HPV negative disease different trial is non-randomized open label to phase 2 trial which is conducted in University of Chicago single university trial following are the steps in which one step is first step is they neoadjuvant therapy. In this, they took nivolumab with paclitaxel 3 cycle. Then they assess response assessment by the CT or MRI before and after the neoadjuvant therapy. and then chemotherapy decide. इन गुड रिस्पॉन्स पेशेंट डीएक्सेलरेटेड कीमोथेरेपी के लिए गए, और अगर जिनमें रिस्पॉन्स नहीं आया उनमें स्टैंडर्ड हमने रखा है। और देन फिर डीएक्सेलरेटेड वालों में कंसोलिडेटेड थेरेपी निमोनिलिमab आफ्टर कीमो रेडियोथेरेपी टू प्रिवेंट कैंसर रिकरेंस। All patient provide written informed consent. The eligibility criteria is untreated, locally advanced, non-metastatic head and neck cancer from the all side with the stage 4 disease. Patient with oropharyngeal cancer were required to have negative p16 test by the ISC. All patients were determined to have unresectable disease defined by the tumor board. स्टडी प्रोसीजर न्यू एडजुवेंट 3 साइकिल दिए उन्हें 3 वीकली, निमोनिलिमab 360 mg फॉर डे 1, पैक्ली 100 मिलीग्राम मीटर स्क्वायर के हिसाब से डे 1, 8 एंड 15, एंड कार्बो AUC 5 से डे 1। उन्हें स्कैन कराए बिफोर एज वी डिस्कस बिफोर एंड आफ्टर द न्यू एडजुवेंट थेरेपी एंड चेक द रिस्पॉन्स असेसमेंट एज पर क्राइटेरिया। The type of the scan used after treatment same as before. Response check, they divide into the patient in 2 groups. Deep response in which 50% or more shrinkage मिला, और जिनमें नहीं मिला less than 50% उन्हें no deep response. Then assign for the treatment. Standard arm जिनमें ट्रीटमेंट नहीं मिला है, रिस्पॉन्स नहीं मिला है, लेस देन 50% रहा है, तो उन्हें स्टैंडर्ड आर्म में रखा है, और जिनमें मोर देन 50% रहा है तो उन्हें डी एक्सेलरेटेड ट्रीटमेंट में रहा है। दोनों में जो रखा गया है कि ऑप्शन 1 में 70 ग्रे 35 फ्रैक्शन विद कॉन्करेंट सिस्प्लेटिन 100 मिलीग्राम मीटर स्क्वायर 3 वीकली बेसिस पे, डे 1 22 एंड 43, एंड ऑप्शन 2 में 75 मिलीग्राम वो 75 ग्रे इन 50 फ्रैक्शन हाइपर फ्रैक्शनेटेड रेजिम with concurrent paclitaxel 5-FU and hydroxyurea chemotherapy in 5 weeks on and week off cycle. सेम डीएक्सेलरेटेड में कीमोथेरेपी सेम है, बट इन्हें जो रेडियोथेरेपी का डोज है वो कम किया है। ऑप्शन 1 में 66 ग्रे इन 33 फ्रैक्शन दिया है, और ऑप्शन 2 में 66 ग्रे इन 44 फ्रैक्शन दिया है, 1.5 ग्रे ट्वाइस डेली। Then for after chemoradiotherapy, all patient got consolidated nivolumab 480 milligram for every 4 week for 9 months. All the patient were treated with IMRT technique. इसमें डिफरेंस ये आया स्टैंडर्ड आर्म में, जैसा कि हम करते हैं कि प्राइमरी ट्यूमर देन प्रोफाइलेक्टिव RT टू द लोको रीजनल नोड्स, और डीएक्सेलरेटेड आर्म में उनने केवल प्राइमरी ट्यूमर विथ जहां नोड इन्वॉल्व है उसी के अराउंड में 1.5 सेंटीमीटर का मार्जिन लेके केवल उसी भाग को ट्रीट किया है, प्रोफाइलेक्टिक नोडल रेडिएशन नहीं दिया। दिस इज द डिफरेंस। फॉलो अप एंड रिस्पॉन्स असेसमेंट at 3 months post CRT, head and neck CT MRI, physical examination by the lab test and PET scan, and later on every 3 monthly for 1 year, and 6 monthly for 2 to 3 years, and once per year in 4 to 5 years. They assess biomarker assessment also, PDL1 expression using by ISC, expressing as a combined positive score CPS using E1 L3 and antibody. The primary endpoint is deep response rate, percentage of the patient whose tumor shrinkage 50% and more after the new adjuvant therapy as per RECIST version 1.1 criteria. The secondary endpoint is PFS, overall survival, loco-regional control, and descent control. They measured for the 2 year. Or exploratory endpoint in which they assess the acute side effect as per CTCE version 5 scales. On the stats, the sample size was calculated for the primary endpoint DRR following neoadjuvant nivolumab with chemotherapy. DRR of 22% was considered as a null hypothesis based on previous historical published data for the chemotherapy alone. A DRR of 40% with addition of neoadjuvant nivolumab to the chemotherapy would warrant further investigation using a Simon two-stage design. targeting a type 1 error for 1.1 and 80% power after enrolling 70% in first stage. The trial would terminated if 4 and few have deep response. And the trial proceed to the second stage for the total 34 patients to be studied. Two additional patients were planned for enroll, total sample size of 36 patients. All time of event, efficiency endpoint, and toxic effect assessment were analyzed in all eligible patients who started neoadjuvant therapy. Analysis plan, deep response rate as calculated as a proportion, 95% confidence interval, and secondary endpoint are PFS, overall survival, local regional control, and distance control at 2 years. Estimating using by the Kaplan-Meier curves, comparative using log-rank tests, significant p-value less than 0.05. Uh, Study total they enroll 36 patient with calculate taken September 2019 to June 2022. Gender mostly are male, 28 males, 78%, and 8 female, 22%. Median is 58.9 years, range 27 to 77 years. Median follow-up of 20 months, range 13 to 40 months. Data cutoff date 1st of November 2023. Then they evaluate all 36 patients for toxic effect and survival outcome, and for primary endpoint like deep response rate. Death during treatment, one patient died after the first cycle of neoadjuvant therapy due to tumor hemorrhage. Disease stage, all patients are stage 4. One patient had stage 3 disease, non-viral mediated nasopharynx primary T3N2B. Uh, this table also same. Treatment feasibility and administration. For this, uh, concert diagram, 43 patients enrolled with the newly diagnosed head and neck cancer, 7 excluded to determine have a HPV positive disease, 4 and non-meet inclusion criteria, and 1 have withdrawn consent. So total 36 patients, 1 died on the tumor hemorrhage due to the, and 35 for the study, and 19 for deaccelerated therapy, in which 9 have taken cisplatin based chemotherapy, and 10 have paclitaxel based chemotherapy, and 16 for the standard arm. 9 received cisplatin based chemotherapy, and 7 received pacli based chemotherapy, and for sent for the follow up. Same. Total 35 patients, so 97% receive all 3 planned doses of the neoadjuvant nivolumab, while 18% को dose reduce करना पड़ा of pacli and carbo. Adjuvant nivolumab was administered in 21 patient, 58%. Among patient who complete neoadjuvant nivolumab plus chemotherapy, 19 were assigned to deaccelerated chemotherapy and 16 for standard chemotherapy. And in the deaccelerated arm, 9 patient को cisplatin based chemotherapy and 10 had same, and same standard arm में 9 को cisplatin based and 7 को pacli based chemotherapy. Efficacy primary endpoint deep response rate is 53%, and 95% confidence interval 35 to 70%. The trial had null hypothesis threshold of 22%. Since 53 is much higher, null hypothesis was rejected, mean the treatment was effective. Over objective response rate, tumor shrinkage 30% and more as per RECIST criteria was 86%, 95% confidence interval 71 to 95%. This meant a lot. 8 out of 10 had significant tumor shrinkage. As per PDL1 expression effect, PDL1 expression shows by the combined positive score, which is 0 से 100 तक कुछ भी हो सकता है. तो they took 2 criteria, but less than 1, more than 1, and less than 20, more than 20. तो DRR for more than 1 में अच्छा है, so 75%, and same is 20%. more than 20 में 63%. For the more than one, it is significant. बट मोर देन 20 और लेस देन 20 में गैप कम है, तो दैट्स वाई जो है नॉन सिग्निफिकेंट है. Interpretation: patient with PDL1 CPS more than one had better response than those with CPS1. They using higher cutoff also did not show significant difference. Survival outcome, PFS at 2 year 66%, means 66% had no disease progression after 2 year, and overall survival is 73% after 2 year. 2 years month outcomes, PFS overall 66% and PFS is 66% overall, and overall survival is 73%. In the deaccelerated arm, 69%, and standard arm also 69%. और overall survival in deaccelerated arm 74% and standard arm में overall survival little bit better. Local regional control deaccelerated arm में 89% and standard arm में 93%, and distant control is 94% in deaccelerated arm and जो standard chemoradiation therapy में 90%, which all are non p value is 0.4, 0.6 and 0.1, which is non-significant. These are the Kaplan-Meier curve showing survival outcome with the time. First curve is progression-free survival, in which blue line denoted deaccelerated arm and dotted line show is standard arm. So at the 2 year almost सेम ही जा रहा है. डीएक्सेलरेटेड आर्म में प्रोग्रेशन फ्री बेटर है, बट सारे बेटर बताए हैं, बट पी वैल्यू इज 0.4 विच इज स्टैटिकली नॉन सिग्निफिकेंट हो जाए. Survival outcome by the PDL1 expression. We have already taken two criteria: less than 1, more than 1, more than 20, less than 20. So PFS at the 2 year, CPS more than 20 88%, and less than 20 में 59%, and same overall survival more than 20 वाले में 88% and less than 20 वाले में 69%. The p value is 0.16%, and CPS more than 1 is PFS 67% and 83% in overall survival, and less than 1 में 60 and 66%. The p value is 0.28%. 0.28. These survival outcome by the PDL expression, more इसमें जो ब्लू वाली लाइन है वो CPS 20 and orange line CPS more than 20 dotted line, which is better. As we talked earlier कि more than 20 में डिफरेंस ज़्यादा है, बेटर रिस्पॉन्स है, बट स्टैटिकली सिग्निफिकेंट नहीं होता है, एज वी डिस्कस इन दिस. यहाँ the safety profile, neoadjuvant phase adverse effect, neoadjuvant phase में mostly grade 3 neutropenia मिला in 8.3%, and peripheral neuropathy मिला grade 1 और 2 का 69.4%, and chemoradiotherapy phase में local regional side effect mucositis standard arm में ज़्यादा है, बहुत ज़्यादा 94%, comparative to deaccelerated arm 74%, and radiation dermatitis 88%, and deaccelerated arm में 68%, and dry mouth 63% in the standard arm and 37% in deaccelerated arm. So by the side effect, deaccelerated arm is better comparatively standard arm. Discussion to our knowledge, this is the first reported trial incorporating immunotherapy in the neoadjuvant setting for the patient with HPV negative head and neck cancer receiving definitive CRT. The deep response rate following neoadjuvant nivolumab plus chemotherapy was 53%, meeting the primary endpoint as the improvement overall historical control of the induction chemotherapy alone. The 2-year PFS of 66% and overall survival 73%, as we discussed earlier, comparative to favorable with historical control approximately 50% and 65% respectively for chemoradiotherapy in stage 4 HPV negative head and neck cancer. We demonstrate similar locoregional with no elective nodal failure, improved distant control, and less acute toxic effect during the deaccelerated arm. These are the benefits. Higher PDL1 expression was associated with the deep response and a trend towards the improved PFS and overall survival. This trial support further development of neoadjuvant nivolumab-based chemoimmunotherapy in non-surgical, locoregional, non-viral mediated head and neck squamous cell carcinoma and support adapted deaccelerated radiotherapy based on the response. Furthermore, patient demonstrating suboptimal response with the neoadjuvant nivolumab plus chemotherapy still show favorable survival compared with historical control, suggesting a positive effect with neoadjuvant chemoimmunotherapy for this group as well. Initially, enthusiasm of incorporating immunotherapy in the curative intent setting has dampened by the disappointing result from the multiple trial. These are the two trial, Javelin 100 and Keynote 142. इन विच सर्वाइवल बेनिफिट नहीं मिले हैं इनमें इम्यूनोथेरेपी को कीमोरेडियोथेरेपी के साथ ऐड किया तो रिजल्ट्स बेटर नहीं आए थे, सर्वाइवल बेनिफिट नहीं थे बिकॉज इसमें हैजार्ड रेशियो 1.21 था विच फेवर्ड द प्लेसिबो. These are the negative trials. And smaller randomized trial similarly did not suggest an improvement with concurrent immune checkpoint blockade with the chemoradiotherapy. In contrast to these approach, our knowledge current depend study is the first published trial incorporate immunotherapy in the neoadjuvant setting with induction chemotherapy in non-surgically treated patient who went on to receive definitive CRT. These are the some positive trial which show survival. सर्जरी से पहले इम्यूनोथेरेपी ऐड किया तो दे shows the response. Neoadjuvant nivolumab with ipilimumab small single arm study before the surgery had a resectable head and neck cancer. The major partial response up to the 83%, complete response 7%, encouraging early results. Neoadjuvant pembrolizumab 1 to 2 cycle before the surgery is a resectable disease. Partial and complete major response 40%. Higher response with more cycle and longer treatment. Keynote 689 phase 3 trial. Neoadjuvant plus adjuvant pembrolizumab in resectable head and neck ongoing. Design confirmed and neoadjuvant semi-plimumab and plus chemotherapy stage 2-3 laryngeal cancer 4 cycle 40% complete response and 77 biopsy completed response, a very high early response rate. These are the positive trial which shows the insertion of the immunotherapy in the as a neoadjuvant arm. For HPV negative disease, treatment optimization is still a big challenge. Adding neoadjuvant chemoimmunotherapy before CRT used as a chance to reduce the low radiation dose up to the 66% and reduce elective nodal radiation volume, which decrease the side effect. All the recurrence happened inside the high volume area. This is important कि जो recurrence हो रहे हैं वो high dose area में ही हो रहा है, not in the area where the radiation was reduced. Sparing lymph node with the radiation might help the immune system to work better. PDL1 findings, deep response rate, PDL1, CPS more than 1 and less than 1. More than 1 में 75% have strong response and less than 1 में 27 strong response. क्योंकि इसमें सैंपल का डिफरेंस है इसीलिए ये ऐसा है. 75% को स्ट्रॉन्ग रिस्पॉन्स है और लेस देन 1 वाले में 27 को स्ट्रॉन्ग रिस्पॉन्स. सिमिलर पैटर्न यूजिंग द PDL1 CPS more than 20 but fewer patient in that group. PDL1 high patient also shows better PFS and overall survival trend. Matches finding from the other immunotherapy trial. PDL1 could be a useful predictive marker. Furthermore, de-acceleration of radiotherapy did not compromise locoregional control at 2 year, 89% versus the 93%. More recently, evidence has suggested the importance of maintaining the integrity of tumor draining lymph node in context of immunotherapy efficacy. Interestingly, our study demonstrated numerical improvement in distant control rate in responding patient receiving de-accelerated chemoradiotherapy. Furthermore, the neoadjuvant immunotherapy trial also suggests enrichment for pathologic response among higher PDL1 expression. Taken together, for the depend result further support the importance of PDL1 expression as a predictive biomarker with immunotherapy trial in curative intent setting may be a important selection criteria for the subsequent trial. These are the limitation of this study. This trial was conducted as a single institution, which may be the limit the generalized findings. The study was not powered to detect difference in the smaller group. Design does not establish whether deep response or other biomarker are best criteria for deciding on the radiotherapy de-acceleration. As non-randomized study, difference in disease burden and primary tumor location between group could affect outcome. The observed reduction in acute toxic effect in de-accelerated group should be interpreted with caution. The study was not powered to detect significant difference in late toxic effect. Additional correlation and biomarker analysis are ongoing and will be reported separately. The conclusion of this study, this is the first trial showing giving neoadjuvant immunochemotherapy followed by response-based chemoradiotherapy may improve survival and reduce treatment side effect in a difficult to treat patient group. These findings support further testing in a randomized trial using biomarker selection patient.